Chest pain accounts for approximately 6 million annual visits to the emergency rooms in the United States every year. Patients present with a spectrum of signs and symptoms, reflecting the many potential causes of chest pain. Some of these causes of chest pain require immediate attention. Clinicians in the emergency department focus on the immediate recognition and the exclusion of life-threatening causes of chest pain. Patients with life-threatening causes for chest pain may at first appear deceptively well, and the trained healthcare professional should be aware of this. Causes of chest pain that pose an immediate threat to life include acute coronary syndrome, or ACS. That's when the blood supply to the heart muscle is suddenly blocked. Aortic dissection, pulmonary embolism, tension pneumothorax, pericardial tamponade, or esophageal rupture. Overlap exists among the symptoms experienced by patients with life-threatening chest pain and those with not life-threatening chest pain. Patient descriptions of their symptoms can be helpful in some instances, but emergency clinicians must guard against prematurely diagnosing patients based solely upon their history. So-called atypical presentations actually occur often, and misinterpretation of such presentations increases the risk for a bad outcome. Patients with an immediate life-threatening cause for their chest pain tend to appear anxious and distressed, and may be diaphoretic or sweating, and dyspneic or short of breath. Testing will further help the ER clinician to diagnose chest pain. Acute coronary syndrome, ACS. You should do a standard 12-lead electrocardiogram. It's an EKG, and it's obtained for all emergency department patients who present with chest pain. Guidelines from the American College of Cardiology and American Heart Association suggest that the EKG be obtained and interpreted within 10 minutes of presentation to the emergency department. The electrocardiogram should be repeated as frequently as every 10 minutes if the initial electrocardiogram is not diagnostic, but the patient still has symptoms, and there remains high clinical suspicion for a heart attack. In the setting of an acute myocardial infarction, heart attack, advanced lab work is done at regular intervals to look for elevations in certain markers in the blood that would indicate a heart attack or an MI. In the majority of cases, a single set of negative biomarkers of this lab work is not sufficient to rule out an MI. These lab tests should be done at regular intervals over several hours. A chest X-ray is obtained in all chest pain patients with hemodynamic instability, that's someone with an abnormal blood pressure or an inadequate cardiac output, or a potentially life-threatening diagnosis, such as acute coronary syndrome. The emergency clinician assesses all patients with acute chest pain for life-threatening causes. Often, a definitive diagnosis cannot be made initially, and additional testing is performed along with other management. The patient's history, other physical issues that they may have, and the patient's description of their symptoms help to narrow the scope of potential diagnosis and to identify the patient's risk for life-threatening disease. The physical exam focuses on vital sign abnormalities and cardiac or pulmonary findings, and that may support a diagnosis. An electrocardiogram and a chest X-ray are reviewed for anything abnormal. Any patient with an abnormal blood pressure, inadequate cardiac output, or significant respiratory distress is admitted to the intensive care unit. Patients not at low risk for ACS, but without known coronary disease or obvious signs of a heart attack, but no clear alternative diagnosis, are observed to rule out a heart attack with a series of blood work, as we talked about before, electrocardiograms, and possibly further testing. Patients at low risk with a normal electrocardiogram are managed in a non-ICU setting on a nursing floor with a monitor or a chest pain observation unit. Additional tests may be done to identify cardiovascular risk for the chest pain patient in the emergency department itself. Patients with an uneventful observation period, negative serial blood work, and normal stress test can be safely discharged with a referral for a follow-up cardiologist. The best way to find out whether you have a legal claim with regard to emergency care you or a loved one receive for chest pain is to discuss your situation with an experienced medical negligence attorney. We have nurse and physician attorneys here at Kolsby Gordon who are here to help you. Medical negligence cases are complicated, and an experienced lawyer at Kolsby Gordon can evaluate your case and advise you about your legal rights and options.